Hello, everyone, and welcome. I'm Dr. Jessica Ailani. I'm the director of the MedStar Georgetown Headache Center in the Washington, D.C. area. We welcome you to our program on new treatments for migraine, and I am joined today by my friend and colleague, Dr. Stewart Tepper. I'm going to have him tell you a little bit about himself and where he's coming from.
Hi, I'm Stu Tepper. I'm a professor of neurology at Dartmouth in New Hampshire and director of the Dartmouth Headache Center at Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire.
I always get hiccuped when I have to introduce others, and Stu has had to watch me do this too many times. He knows better than to let me do the full introduction. So without further preamble, we're going to talk to you a little bit about all the different treatment options in migraine. It's been an extremely exciting time in our field, and before the program started, Stu and I were talking about our recent meeting that just completed the International Headache Congress, and we're going to end our program telling you about so much new stuff and excitement, but just to give you a little taste, it was so amazing, the new targets that are out there, the new treatments that are on the way, that I could not keep up. It was overwhelming. It was probably the most excited I have felt in the last 3 years, and boy, has this been some last 3 years of my life. So Stu, I thought we'd start by talking a little bit about acute treatment for migraine. And this is an interesting space. This acute treatment, every patient who has migraine needs to take something for their migraine attacks. This is what we call acute treatment. And, acute treatment, I feel like someone who has come into the field, I came into the field, the triptans have been around a long time, but people really tell us the stories of the first time they used a triptan and what that experience is like. And I'm sure, Stu, you probably have a story the first time you've given a triptan in your life and what that was like for patients.
It was completely remarkable. I remember a woman coming into my office. We had a full waiting room. She had a terrible migraine. She was in real distress. She looked awful. And we gave her a shot of sumatriptan in the back room. And within 10 minutes, she was normal and looked completely different and walked out. And everybody in the waiting room said, "We want what that person just had." It was absolutely astonishing.
Yeah, and I hear these stories from my patients, from my colleagues, and I think like, I was always a little jealous that I didn't get that experience. And so it's been a really nice time to be part of this revolution where we've had some of these newer treatments. So when we think of acute treatment, we're thinking of, okay, somebody's having a migraine attack. They're having moderate to severe pain. They're nauseous. The lights are bothering them. They come in really disabled. The sounds are bothering them. And they want to take something that the migraine attack goes away, the light sound sensitivity goes away. I think of it as a patient who comes in with the dark glasses, the puke bag in their hand, and they leave the office, the puke bag's in the garbage, the glasses are off, and they're happy and they're laughing and making jokes with me. That's successful treatment, and it happens that quickly. That's really what we're looking at with acute treatment. And so we think about acute treatment as tablets that you can take, nasal sprays, injectables. And in the last few years, we've had some new tablets that have come to market that have really focused on a change in how we're treating migraine because they're new targets. And we've looked at medications that are targeting CGRP, which is calcitonin gene-related peptide. It's a protein that we know is involved in causing migraine. And if we change its amount in the body, we can also reduce a migraine attack when it's happening. So there's been some new acute treatments called GPANs, very funny name, that target the CGRP receptor, and they can be used as tablets to take as needed during an attack and can stop an attack when it's happening and also reduce associated symptoms like light sensitivity and sound sensitivity, and patients can be more functional after. The nice thing about these new treatments, which are commercially sold as ubrogepant or rimegepant or Ubrelvy and Nurtec, is that they really have very few side effects. So it's kind of a step away, a step different than the triptans, which I still think are wonderful, fantastic drugs. And patients really tell us they change their lives, but sometimes they can give patients side effects where they feel really tired or it's hard to function after using a triptan. And then this is where the GPANs have really stood out. They really are pretty well tolerated for patients. Stu, how's your experience been? How have patients liked the Gepants in your clinic? Do they feel like they're well tolerated? Are they working well? Do they prefer that? Or do you really find like it's a mix of when you use one or the other?
We do have a mix. Gepants are extremely useful because they do not cause blood vessels to narrow, and so they appear to be safe in people with blood vessel disease, vascular disease. Triptans cannot be used in people with vascular disease. Gepants are a bit slow in their onset, and so because they don't have side effects for the majority of people, we have the opportunity to tell people to take them really, really early and to prepare that they may take 2 to 4 hours to work, but because they can take them so early and have no side effects, they can be very effective, especially for migraines that occur during the day. And we don't really care if the person was going to get a really bad migraine or a not so bad migraine, and they won't care either because they don't have any side effects. The other big difference with Gepants, which is really helpful, is that they don't appear to cause the transformation from episodic to chronic migraine. That is, the more people take Gepants, the less headache they have. Kind of the opposite of when people take too many triptans or too many analgesics or combination analgesics where they get a rebound. Gepants don't appear to cause rebound. And in fact, one of the Gepants, Rimegepant, which has the brand name Nurtec, as Dr. Ailani said, has actually been approved, and we'll come back to it, has been approved by the FDA as the first medication approved for both the acute treatment of migraine and the preventive treatment of episodic migraine. Therefore, the Gepants really represent a significant change for us and one that's really favorable for patients. The other new acute treatment that was approved in the last 3 years works by a completely different mechanism. Gepants target CGRP. The other new medicine is called lasmiditan, or Rayvow is the brand name. Gepants work outside the brain. Lasmiditan goes into the brain. And inside the brain, where its major effect is, it turns off the migraine inside the brain. Now, that means that some people will get dizziness or drowsiness or a mild intoxicated feeling, and we have to work on picking the correct dose of lasmiditan for people. And also, the FDA prohibits anybody from driving for 8 hours after they take lasmiditan, even if they don't get the dizzy drowsy, because it can affect coordination. Again, lasmiditan does not affect the blood vessels. It works on the old target serotonin that triptans and ergots target. Dr. Ailani, what has been your experience with lasmiditan?
So I agree that it can be sometimes difficult because of the central nervous system, the brain side effects. But you know, it is nice to have these options. Sometimes a patient has these mild to moderate slow uptick in their migraine. They can really tell. That's when a Gepant's really great. But sometimes they get the kind of migraine, it just slaps them in the face. It's really harsh. It's terrible. They take their Gepant. It doesn't quite do enough, and they need what I consider a rescue. And this is really where I think lasmiditan shines. It's great for later in the day migraine, a rescue to a Gepant. It was not studied this way. I want to make it very clear. But mechanistically, it makes a lot of sense. You take a drug that works on the outside of the brain and you combine it with a drug that works inside the brain, and you have this amazingly perfect combination of getting rid of all of the stuff that's triggering migraine. And also, when the migraine gets that bad, the patient wants to sleep. You want to shut that system down, and it causes just enough drowsiness. My patients tell me, you know, I rest for an hour or two, I wake up, and the migraine's gone. I think it was just because I slept. I'm like, no, it's the medicine. Because if you just took a nap, one, it would be really hard to fall asleep when the migraine's that bad. And you know you've tried taking a nap before. It never really shut that migraine off for you, especially not as we get into our 40s and 50s. And migraines, they become relentless. It's not easy to just turn it off by sleeping. Usually they just progress. And that's the beauty, I think, of lasmiditan, that I shut my brain down, I take a nap, I wake up, and I'm really clear. There's no migraine, there's no lingering post-drome, this icky feeling that I get when the migraine is done. But it is a little tricky to find the right dose. So really, I tend to start on the lowest dose for my patients and tell them it might not work the first time or two you take it, but you will adapt to that sedation feeling, and then we can increase the dose and really find that right fit for you. And in the right patient, it really can be a very good drug.
I completely agree. I completely agree. That's almost exactly how I use it. I have people use it later in the day. I have them use it in the evening. I have them use it on weekends when they don't need to drive. I use it for patients who live in Manhattan and don't have to drive at all. And it can be useful in combination, and it works faster than GPANs.
Yes,
So we have these nice new options of tablets that work by new mechanisms beyond the 7 triptans, and it's quite helpful and quite encouraging.
So we've been talking about new mechanisms. We do have some old drugs with fancy new devices that have been put on top of them that are coming out, just got FDA approval, just coming out now to market. And an example of this is DHE, which is, to any headache specialist, their tried and true friend. I feel like, you know, DHE, we wear it with a badge of honor. It gets us out of any kind of muck of trouble we get into when a patient's really in trouble. And we tend to use it when a patient does not find a triptan to be effective. And in particular, these patients who maybe have tried some of the new stuff and they might not find that to work fast enough or well enough, and perhaps needs a non-oral option. So many of our patients are familiar with nasal formulation DHE, but sometimes it's hard to obtain because of insurance issues, or it was difficult because it caused trouble. They'd get it into the nose and it would leak down the back of the throat. So there's been some new developments where there's a pod technology that's been formed that sits on top of the former nasal spray DHE. And this new drug's come to market under the brand name Trudesa. And this is just one spray each nostril of formulation DHE, a drug that we're very well familiar with. And it's able to get deeper up into the nasal cavity, past an area that has a tendency to leak back down into the throat, and we get a much better absorption into the system. We think that it was going to work much better to treat migraine attacks when it's happening. And so I'm really excited to finally get this back into the game and to have that back into our patients' hands and really put it into the rotation for patients that are having migraines that are not easy to treat with a triptan, or are having a migraine that tends to last longer. I find that DHE is very helpful in patients that have long migraines, especially the day 2 relief that they tend to experience. They feel better that day, but they can also feel better the next day. I find this a typical experience with use of DHE. And they're like, not only do I feel better today, but I was really functional the next day and the day after too. So it really helps clear up their migraine attacks. So it's going to be especially useful for people who have menstrual migraines, so this number of day attacks, where it can really help clear those days out. It's so new. I don't know, Stu, if you've even had the chance yet. I mean, this just came out like the other day, so it's very exciting. And I'm going to be curious of how we get our hands on this stuff and use it in clinical practice.
Again, I agree with you. A DHE are my 3 middle initials, and it's such an important drug for us. And just to reiterate a few of the points that Dr. Ailani made, DHE can work deep in an attack and give a complete response. And very often triptans don't do that. And the best example of that, the most common situation where that occurs, is morning migraine. And as anyone with migraine will tell you, almost half of migraine attacks are in the morning and the horse has already left the gate. The person has already got very significant disability upon awakening. DHE can work deep in attacks. It can reverse that, whereas triptans don't do that as well. The other point about DHE, as Dr. Ailani said, is that that once a person gets a complete response, the headache tends not to come back. It gives a sustained response. And that's the situation for menstrual migraine, which can be very long attacks. And DHE works also as a rescue. Again, it is a medicine that can work when the migraine has escaped, and it can control a migraine that is resistant to treatment. It's extremely useful for us. And it has been a great disappointment that we haven't had a good, available, affordable home treatment of DHE. And the hope is that this new DHE formulation will be both accessible for patients and more effective than the previous liquid nasal spray.
Yeah. So speaking about tried true favorites, another one of my favorite drugs are nonsteroidal anti-inflammatories. Now we are out of the specific treatments for migraine, as nonsteroidal anti-inflammatories are not specific for migraine treatment. And many of our patients would have tried nonsteroidal anti-inflammatories from over the counter, like ibuprofen or naproxen, before they even come in to see us. But we do, and we have been over time, growing the number of nonsteroidal anti-inflammatories or NSAIDs that are being used and studied for acute treatment of migraine. And I often find that these can be helpful in patients who've had a number of side effects from other treatments for acute migraine treatment, and also as an add-along treatment to just about any other treatment that we use for migraine attacks. And sometimes our patients would prefer to start with an NSAID before going to what they consider their powerhouse meds. And even though sometimes, especially with a GPAN, I'm not concerned about rebound, but the patient might be a cost issue, wants to kind of hold on to the number of tablets they have, they might prefer using an NSAID first. So there has been in the last year an update and then FDA approval of a new NSAID option. So I'm excited to be able to use this. It is not yet to market, but it probably will be coming soon. So please don't go asking your providers about this just tomorrow. It's not yet out, but we are telling you about this special information. It's celecoxib oral solution. It's going to come in a little glass bottle, all ready and mixed, and you can just drink the solution when you're having a migraine attack. And it's a COX-2 inhibitor, one that we're all familiar with when it comes to pain in other regions of the body, safer for your stomach. The main side effect in the studies was just a funny taste in the mouth. I mean, that's not surprising. It's liquid that you're going to taste an NSAID. It's going to taste a little funny, but I think that it's a really nice additional treatment for us to have for patients to use during an attack, to have as an add-on. Again, not studied as an add-on, but you can tell I really like to add treatments on for some of my patients. So I'm very excited to be at some point able to prescribe this for my patients and see how they really like this treatment option. What do you think about a liquid glass bottle? You think that this is going to go over well with our patients?
I think it'll be okay. Unlike the DHE we were just talking about, which should be available by mid to late October, the liquid celecoxib, which is also going to be available this fall, on that study, I was actually an investigator, so I do have some experience with it. And what is great about liquid nonsteroidals is that they work fast. And they work, again, in a rather complete way. They can work rather deep in an attack, and they can, as Dr. Ailani said, you can add them to the other treatments and get synergy, even though they weren't studied that way. The brand name of the liquid celecoxib is Elixib, and so you'll look for it, and the hope is that there'll be access with this particular liquid celecoxib, and that once again we'll have a new treatment that is old wine in new bottles. It's in this case real bottles, and but I can say from the study that patients did like it. They did find it effective. They did find it fast, and they did not have a lot of side effects except the unusual taste.
Yeah, I think that's nice. I will say I kind of like the glass bottle idea because in some states that's recyclable. I think we do have to watch all these plastic containers and little pouches that we're creating. So we are creating a lot of waste. So let's talk a little bit more about devices, because of course, headache is so much fun because we have procedures, we have medicines, we also have these cool devices, which we call using neuromodulation, where we're trying to change the way the brain is working without implanting a device in your brain. And it's very cool because we can do this by changing the way the nerve is sending information back to the brain, or changing the way the brain is turning on and off the pain lever. I like to think of it that way. And we have several different neuromodulation devices that have been studied for acute treatment in migraine and FDA cleared. There's the supraorbital transcutaneous stimulator that's known as the Cephally device that sits right on the forehead. There's the STMS device, a transmagnetic stimulator that you hold to the back of the head, and you push a button and it sends a magnetic stimulation wave across the brain and changes the way the brain is sending bad signals the wrong direction. That's how I like to think of it. Not very technical, but there's also a non-invasive vagal nerve stimulator that's handheld. You put right on the neck, and it sends little electrical pulses to one of the nerves that goes from the gut all the way to the brain. And we know in migraine there's a huge gut-brain connection. But we're not changing the way we're not trying to change the way the gut is working here. We're actually changing the way this nerve is submitting information to the brain. And then the studies have shown that over time, with use of this device, we're changing the brain pathway, and it's changing the way the brain is accepting information about pain. Very fascinating studies that all of these devices have. And then we have a remote electrical neuromodulation device I call the Band-Aid, because it sits like a big Band-Aid on your arm. It's controlled by your smartphone, and you turn it on for 45 minutes. And this turns the shut-off valve in the base of the brain that tells your brain, no more pain, shut it off. It's very, very cool, and it has very minimal side effects. Then there's the newest device for acute treatment that's just been FDA cleared. Again, not yet available, but we're telling you what's coming your way. And this is the Relivion device. And so Dr. Tepper, you want to tell us a little bit? You were one of the principal investigators here, so I'm going to let you share with our audience a little bit about this device.
Let me give you the background on it. Happy to. Let's go back to the Cephally device first. The Cephally device, as Dr. Ailani said, sits on the forehead, and it has a program for prevention of migraine and a program for the acute treatment of migraine. We're talking about the acute treatment. And when the acute treatment is turned on, it turns on the device for an hour and then turns off. And a recent study that was presented at the American Headache Society meeting in June suggested that for people that tolerate it but don't get completely pain-free with 1 hour, if they turn it on again for a second hour, they can get pain-free. The problem with the Cephally device is, number one, it's only connecting from the front. So it does send a signal into the brain to turn off the migraine, but it's only doing it through the system called the trigeminal system. And second, some people find the Cephally device unpleasant, that it has these really weird sensations that can be actually unpleasant. The new device, which, as was said, is called Relivion, sits on the head as a crown, in a very lightweight crown, and it has a section that sits right where the Cephally device sits, but it also has a stimulator at the back that goes over the greater occipital nerves. And the greater occipital nerves are a different system that get into the brain, and they converge at the same place that the trigeminal system comes into the brain, in the lower brain stem. And the Relivion device turns on what I consider to be an inhibitory turn-off signal from the front and an inhibitory turn-off signal from the back, turns on for 45 minutes, turns off the migraine, and works. It may work better than the other systems because it's combining. We don't know yet till we have a lot of experience with it, but it's hopeful, and it's going to be available probably in the first centers at the end of October of 2021, and then be rolled out gradually over the months that follow. Again, Relivion is an as-needed treatment. Cephally is both an acute treatment and a preventive treatment. And the arm device that Dr. Ailani talked about, Nerivio, is only an acute treatment. And the STMS device, the magnet device, is approved for both the prevention of migraine and the as-needed treatment for migraine. And then, as Dr. Ailani talked about with the non-invasive vagal nerve stimulator, which is called GammaCore, that does a lot of things. And it is FDA cleared for the acute treatment of migraine, for the preventive treatment of migraine, for the acute treatment of episodic cluster headache, as an add-on for the prevention of cluster headache. And in the third week of September, it was cleared by the FDA to prevent 2 other rare headache disorders for which we have no FDA-approved therapies, and those are paroxysmal hemicrania and hemicrania continua. We're pretty excited about the prospect of having a non-invasive device that can prevent or acutely treat all of these headache disorders. And every single one of these 5 is designated by the FDA as non-significant risk devices, meaning they don't have significant side effects.
Yeah, it's exciting. And that even some of these devices are clear to use in pediatric indications as well, which is nice because we don't have much in the way for treatment in children. So anytime we have a device that can be used in children, it is really nice that they can use a non-medication option for treatment as well. So I believe the non-invasive vagal nerve stimulator is approved in adolescents or cleared in adolescents. And I think the STMS device, am I correct, Dr. Tepper? I'm trying to remember.
I think it's the Nerivio is the other one.
Yes.
Yeah, I think it's Gammacore and Nerivio. One thing we need to mention, though, and that is the problem with access for these devices. The good news is that if you're a veteran, the VA pays for all of them. The bad news is that none of the commercial plans pay for any of them, or almost any of them. They are in a kind of a list of which is most expensive, and I won't go through it, but there are a few of them that are affordable for most people, but you have to pay out of pocket. And talking to your headache provider, they'll know which ones you might be able to afford. They'll discuss it with you and what the plans are. Those plans can change from month to month, but it's really important to be aware of the potential costs and to make your decision based on what you're trying to accomplish and what the costs are. One last point is that in the UK, the single pulse transcranial magnetic stimulator, the STMS, has approval for use in pregnancy. And that allows for, that's very useful for my patients who are either planning to become pregnant or who are pregnant, as long as they can afford it.
Yeah, it's a good point. So in the time that we have remaining, let's talk a little bit about prevention. And while every patient with migraine needs an acute treatment for their migraine attacks, about 40% of patients with migraine at some point during their migraine career will probably need a preventive therapy. What a preventive is being on a treatment that helps reduce the frequency of migraine attacks, and that really helps to reduce your disability and the burden of having this disease itself. Preventive treatments always should include lifestyle changes and, making sure you're eating on time, that you're not waiting too long to eat, keeping yourself hydrated, exercising frequently, and that exercise should include moderate grade exercise, perhaps some yoga, stretching, relaxation therapy, even including sleep hygiene, sleeping on time, waking on time, and should also we're trying to start to incorporate things like relaxation therapy, stress relief, mindful-based stress reduction, cognitive behavioral therapy, biofeedback, sometimes acupuncture. These things actually have a good amount of evidence behind them, but again, there can be a cost associated with them. They're not always covered by insurance. We're going to focus a little bit on medication, and we talked a little bit about neuromodulation for prevention. So I wanted to bring us to talking a little bit about some of the newer preventive therapies in migraine, specifically focusing on CGRP, because probably in the last few years, this is where the greatest excitement has been. And to start us off, I just want to tell a quick story, something I saw today. A patient who's been seeing me for a long time, she has chronic migraine. When I first met her, she had about 25 to 28 days a month of migraine. She was taking a triptan every one of those days. She had some fantastic provider who was giving her a lot of triptan and not telling her that was a problem. I had started her on treatment, and for a long time she was on onabotulinum toxin and doing pretty well, about 5 to 6 migraine attacks per month, not much else, triptan working great, all was good. And then in the last few years, things really started to change. Some life stressors, work stressors, she has sleep apnea, it was really not well controlled. Had some major sinus surgery, and onabotulinum toxin just wasn't going so well. So 3 months ago, we stopped the onabotulinum toxin because she's like, this just isn't working. It's painful. I don't want to do it anymore. And we started her on a CGRP monoclonal antibody. This was 3 months ago. This is a woman who when I saw her 3 months ago, was for 2 or 3 months having 20 days of migraine a month and overusing a triptan. I saw her today. In 3 months, she's had 2 migraines. 2 migraines. She lost 10 pounds because now she's exercising every day. She looked fantastic. She's like, I have the best sleep of my life. I was just looking at her. I'm like, what? She had her hair all done. It was all colored. She looked great. She started using an app to track her migraines, but she has no migraines. So she couldn't even find when her last migraine was, because now she's using the app to track sleep, which I didn't even know this app that I told her about tracks sleep. So it's just, it shows you our drugs that we've had before, they were great. And many of them are still wonderful and work well. I love onabotulinum toxin. It has been life-changing for patients. But this new category, Dr. Tepper, so every day I have one of these. It comes in and it just throws me. I'm like, my goodness, 3 months, 2 migraines, So
Every single day. Every single day we see a patient say, my life is completely changed. And if that happened once or twice a month 5 years ago, I was doing great.
yeah,
But now, if I don't hear it every single day, I'm surprised. And I hear it
what did I do
multiple
wrong?
times.
So let's talk a little bit about this new class, the CGRP monoclonal antibodies. They're again targeting this protein that we know is involved in migraine. And a monoclonal antibody, these are drugs that are specifically designed to bind either to the protein or go where the protein's supposed to go. So I think of it as being, if the protein is a car and the antibody, and the car has to go in the garage. The antibody is either standing in front of the garage and doesn't let the car park, or it's sitting right on top of the car like a giant heavy magnet and won't let the car move. And it's either one of those. That's how the antibodies are working. So it doesn't let the car go where it needs to go to kind of get to the next step. And we've found them to be pretty successful. There's 4 that are on the market. Arenumab, which was the first to market, and that one is standing in front of the garage. It's the only one that does that, so it's unique. Its brand name is Aimovig. The other 3 are sitting on top of the car like the heavy magnets that don't let the car move. They bind to the CGRP ligand, and that's fremonizumab, eptinizumab, and galcanezumab. The big differences between them, well, one is that Aimovig or Arenumab is the one that binds to the CGRP receptor, so a little different, can cause constipation. Post-marketing, since it's been out the longest and to market, we've seen that there's been some case series, so there's been a label update that it potentially can cause increase in blood pressure and hypertension requiring you to start medication in patients who have borderline blood pressure. So if you're already on the cusp of high blood pressure, this might not be the best option for you, or if this is the one covered by your insurance, or this is the one you really believe in, or this is the one left that you haven't tried and you want to give it a try, you need to have your blood pressure checked usually a week or 2 after you start the medication to ensure that it's not starting to change. As for in the post-marketing studies, most of the time the blood pressure changed a week after the start of the medication. The other 3 medications generally well tolerated. The biggest side effects for galcanezumab and fremonizumab is injection site reactions. Both of those, as well as the Aimovig, are all at-home auto injectors that you can do yourself. They are monthly, though fremonizumab, which is a Jovi, can be done 1 injection once a month or 3 injections every 90 days. And what we say, it has the longest half-life. In my mind, that means it sticks around a little longer than the others. So sometimes in patients, I see less of a wear-off with that medication than the other 3. The last one, eptinizumab, which is Vyepti, is actually an infusion that's done once a quarter. Now, why would you choose to get an infusion versus do it at home as an injectable? Dr. Tepper, what do you think about the infusions? What kind of cool data has come out that might make you think about an infusion for a patient with migraine versus an injection?
The way that I think about Vyepti or eptinezumab is that it was developed, the scientists who developed it decided that they would make a compound that would grab the CGRP with and hold it tighter. So it's like a bigger magnet on top of that car. And in doing that, they anticipated that the eptinezumab would last longer. And they wanted to make it so that this extra power of grabbing onto the CGRP would be increased even more by giving it intravenously. And what I use eptinezumab for is for people who have had partial response to the injected medications at home, who either have episodic migraine, meaning that they have headache less than 15 days per month, or who have chronic migraine, but for whom, for whatever reason, onabotulinum toxin A or Botox wasn't something that they chose to continue. And where do you go when the effect of the injectable at home is only partial? Can you get more headache-free days? Can you get shorter headaches, less severe headaches? And my experience with eptinezumab, and we were approaching a couple of hundred patients now with it, is that it does give an added boost. You're moving up the scale. Eptinezumab has two doses. It has a 100 milligram dose and a 300 milligram dose. We usually start with the 100 and hold the 300 in case the 100 is not giving that added boost. But I saw a patient today, sounds like your patient, who on 100 milligrams, who got 100 milligrams 2 months ago and has had one migraine since. And she had had a very partial response to a couple of the injected at home and no very good response to onabotulinum toxin A. So that's where I think the eptinezumab can be very useful. It's quite powerful, and yet it's very rare to see a side effect with it. Doesn't cause an injection site reaction. And when I was in the study on eptinezumab, we couldn't tell whether somebody had gotten the active drug or the placebo, except that the people who got the active drug stopped having a headache. And that was really the only hint that we had as to which they got. So that's the way I use eptinezumab. Has that been your experience as well?
Yes, we tend to use it in somebody, well, few interesting cases. So yes, 100% like what you're saying, a partial response is a good time period. I often will think of it. I'll think of it in a patient. I've had some patients who finally fess up that they've been too scared to do their at-home injections, and or they've done it a few times and it was painful and they just got too scared and they didn't have anyone else around them to do it for them. And I've noticed this you were doing really well and now you're not doing so well. Like, what's really going on? And they're like, I can't do it anymore. And I've talked to them about switching, and they are coming in for the infusion. They're doing better than they were before because they're able to consistently get their treatment, and they really tolerate it well. They're like, it's a 30-minute nap in the middle of my day. I have no problem with that. It's so fast. And patients are having growing injection site reaction. So usually the rare injection site reaction does not bother the patient. In fact, most of my patients beg me, please don't change my treatment. I'm doing so well. This is a tiny little bump. It's not a big deal. Every once in a while, I get a patient whose tiny bump starts to grow every month, and it's getting larger and larger. And now I'm getting nervous and the patient's getting nervous. I've switched them to eptinezumab and they've done well. And then I've had patients when I have tried everything, every monoclonal, onabotulinum, every combination of everything. And then when eptinezumab came out, I looked at them, they looked at me, and I said, well, why not? And I am surprised that I am getting response. And I think it is a powerful grab for CGRP. And I am seeing one interesting fact that we do see in the data and has been studied, where you can get a very fast, I'm talking about a 2-hour response with eptinezumab. They actually looked at patients who had a migraine and started treatment then, and we're seeing that compared to not getting the drug, you can actually get a response in 2 to 4 hours, which is very amazing. That when you look at a patient's calendar, especially one who has headache every day, because it's very easy then to see day to day how they're doing, and you bring them back like the month after their eptinezumab infusion, and they had what they consider a random couple of days with no migraine. I'm like, that's not random. It started the day after your infusion and you went 4 days in a row, and that hasn't happened since I met you, and you've been with me for a decade. And they're like, yeah, you think that was the infusion? I'm like, yeah, that's exciting. And you see that signal right away. I think It's really exciting to see that. So those are some of the cases that I'll use it. And I'm starting to bring it up. I feel like as this pandemic, at some time when we're able to really clear the way, and the idea of going into an infusion center is not as nerve-wracking to people, and time goes on and we get more and more comfortable, I feel like it's going to start to become an easier option for patients who are like stuck in status migrainosis and aren't on a preventive but have tried other preventives, that I'm going to be like, I think this is the one you should start with, because maybe I'm going to see the response within a few hours that gets rid of that migraine and can stop your migraines for the next few months. It's like one and done treatment, 30 minutes and I cure your migraine now and I protect you for the next few months. That's really where I would ideally like to see this drug. It might take us a bit before we get there, but that would be my hope. So one or two last things that I thought we'd bring up before we end. We have some exciting new drugs kind of filtering, waiting FDA approval. So you want to mention what's...
Can
Yes.
I interrupt?
Yes.
There's one other thing we needed to cover though, before we get to what's coming. And that is, I think we should return to the issue of rimegepant.
Yes. Oh,
Because
yes. We totally forgot to really delve into rimegepant as a preventive.
Rimegepant, remember, is brand name Nurtec, and rimegepant was approved by the FDA last year for the acute treatment of migraine. We already told you about that, but we did mention that the more the people took rimegepant in the studies, the less headache they had. So the company that makes it decided to do a preventive trial with rimegepant, and they included people who had episodic migraine. Most of the people in the study had episodic, but some had chronic migraine. And they gave the rimegepant every other day, and it worked. It worked for the episodic patients. It worked for the chronic patients. It was effective prevention, and the effect was similar to the monoclonal antibodies, and there were not side effects with taking it because rimegepant is so well tolerated. For whatever reason, the FDA said, oh, you didn't have enough chronic migraine patients in your study. And in June, they approved rimegepant for the prevention, but only of episodic migraine. And they sent the company back and said, you got to do another study of chronic migraine. I really disagree with that. I think migraine is migraine. And I think that's what we've learned with the monoclonal antibodies. And I think it puts people into a study where there's going to be a placebo control where it's unnecessary. But in any case, we're stuck with this. So for people that have high frequency episodic migraine who don't want to take an injectable, or have had bad luck with an injectable, or get a bad injection site reaction, and so on, the every other day rimegepant is now FDA approved, and depending on access, is a very good option for prevention. And it is the 5th of the new preventive medications that has been approved since 2018. Did you want to add anything on, Dr. Ailani, or you want to move to what's coming?
Well, I just want to say it is exciting, especially for the patients that are they're like on the cusp of wanting or needing prevention. You really think they should be on prevention? They're unsure, so reasonably unsure, because they're like, I don't want a medicine every day. Well, this isn't a medicine every day. And guess what? Take it every other day. You don't like it every other day? Change it back to as needed. You need a little bit more protection another month? Change it back to every other day. That kind of flexibility for so many patients with migraine. You know, the average patient with migraine has 2 to 4 migraine days per month. Flexibility is really what you need. And this drug, that's flexibility for you. And so I think that for my patients who are like the 12 to 15 days a month, they don't love it because they lose their acute. When you take it every other day and you get 16 tablets a month, then you can't take it as needed, and it becomes a problem because they love their Nurtec as needed. So I love it for my lower frequency and that flexing about what they want to do month to month. And they love it for that reason too. And it can really work so beautifully well. So let's talk a little bit about atogepant that's pending approval, and anything else you know that might be pending approval in the next couple of months, perhaps, before we end our program today.
Atogepant is the next gepant, and it is given daily for prevention. And the only study we have on it was for in terms of study presented to the FDA, there were 2 studies on using atogepant for episodic migraine, meaning less than 15 headache days per month. It's a single pill taken every day, and it looks like it works extremely well. You would expect it. Both the rimegepant and atogepant do, as Dr. Ailani said, they're blocking the CGRP receptor, so they're preventing the CAR from coming in. And the side effects with atogepant were very low. The most frequent side effect at about 7 to 8% was constipation, because it does work similarly to arenemab, Aimovig. But we expect the FDA to approve atogepant on a daily basis for prevention this in the fall of 2021, and look forward to it. That makes 2 gepants that we can use preventively, and somebody might respond to gepant A and not respond to gepant R, and vice versa. So the more we have, the better.
The better. It is interesting because we already see that with the gepants. I have patients that respond to ubrogepant and not rimegepant, rimegepant, not ubrogepant. And so I'm not going to be surprised when this happens. Though mechanistically, you're always like, well, aren't they similar? Well, no, they're a little bit different ring structure, and it's like the triptans. You never know when one will work for someone versus another.
The other medicine that's before the FDA is on the acute side, and it's a mixture of rizatriptan and a formulation of the anti-inflammatory meloxicam, which used to be called Mobic. And as Dr. Ailani says, when you combine a triptan with an anti-inflammatory, the whole can be greater than the sum of the parts. And this, we expect, again, an approval for this combination rizatriptan meloxicam this fall. Gives us another bullet in the gun to fire at a migraine in an as-needed manner.
Yeah, so it's definitely an excited time. And as I mentioned at the start, we just had the International Headache meeting, and there are multiple targets that are underway in studies, all in really basic starting times. But if we can even get one of these targets to prove efficacy and create a drug around it, our future is very, very bright. So if you're watching this program and you have migraine, or a family member has migraine, this, as much as migraine is terrible, not only is this an exciting time for the field, but it's an exciting time for your family and your family members. It's really quite an amazing thing. We have so many new drugs, so a lot of hope out there. If for some reason what we have isn't working because we don't have the right targets yet, hang in there. There's plenty of stuff that's coming out in the way, and it's really been a great time to practice. So any other words you want to say, Stu, before we end the program today?
I just want to underline how much hope there is right now. I've been practicing doing headache medicine since Ronald Reagan was president, and this is by far the most exciting and hopeful time in my professional career. And I look forward to going into the office every day because of all of the options I have for people, and knowing that more are coming. And it's just an astonishingly hopeful time. And I just love working with Dr. Ailani and talking about this with you, because it is so great. We have so many good options for patients.
Yes. Well, thank you all so much for joining us tonight. We always love to chat and talk about these kinds of things. So we hope you've learned a lot and that you feel good about what options we had. And if there's something you heard that sounds good to you, take it back to your healthcare provider. Remember, some of this stuff might not be available yet. So take notes and watch on the internet, because trust me, when FDA approval comes, it's loud like a bell and everybody hears about it. So keep in tune. There's lots of stuff hopefully coming by the end of this year. Take care, everyone.